Hi everyone, it's Derek here from AduMed. So welcome to today's video based on the management of osteoporosis. I'll take you through what you need to know about this to get through your exam. Specifically, we'll be looking at our options in relation to conservative and medical management. We'll look at our medication side effects and also our approach to assessing patients that are on medication. So for all of that and more, keep watching. Let's dive straight in. So our management options can be split into conservative and medical. When we think about conservative management, lifestyle advice here is really important. We should advise a healthy, balanced diet full of vitamin D and also other minerals. We should also encourage smoking cessation and also advise the patient to reduce alcohol intake to 2 units or less per day. Exercise advice here should also be targeted specifically towards weight-bearing exercises in this condition. Let's think about medications because our first line treatments include our oral bisphosphonates such as alendronate or risedronate. Second line treatments are used if oral bisphosphonates are not tolerated or if they're contraindicated. In these cases, we can consider referral for other options such as IV zoledronate or denosumab. Third line options include raloxifene or HRT. So possible side effects of bisphosphonates include esophagitis, asymmetrical femoral fractures, osteonecrosis of the jaw, and conditions such as AF and hypocalcemia. We tend to give patients advice about the use of bisphosphonates, so we advise them to swallow the tablets whole with plenty of water whilst being sat up. This also should be taken on an empty stomach, preferentially at least 30 minutes before breakfast or any other oral medications. The BNF also suggests that the patient should stand or sit upright for at least 30 minutes after taking the tablet, and one of the reasons possibly for this is to reduce the incidence of esophagitis. So I thought it would be really interesting to take a look at glucocorticoid-induced osteoporosis. Bone loss and increased fracture risk can occur pretty early on when starting oral glucocorticoids. So there are three main conditions in which we can consider treatment with bone protection straight away for glucocorticoid-induced osteoporosis at the same time that glucocorticoid therapy is commenced. So what are these three conditions? Well, firstly, this will include patients who are on steroids who have had a fragility fracture, women over 70, postmenopausal women and men aged 50 years or older who are on high doses of glucocorticoids. So a high dose is defined as if the patient is taking 7.5 milligrams per day of steroids or more. So current NICE guidance suggests that patients that are on alendronate need to be reviewed after 3 years and after 5 years for all our other medications. Now our high-risk patients will need to be on alendronate for about 10 years. If not high risk, then we arrange a DEXA scan. If the T-score is equals to or less than -2.5, we can then continue treatment and reassess risk with a DEXA scan every 3 to 5 years. If the T-score is more than -2.5, then we can consider stopping treatment and reassess the risk and repeat a DEXA scan in 2 years' time. Thank you so much for watching today's video. If you found it helpful, don't forget to leave a like and subscribe. Also, make sure you check out our previous video where we go through a little more detail about the background of osteoporosis. Keep posted and I'll see you soon.